Good day to everybody joining us today in this ninth webinar on the Dubai Shoulder course. Speaker will be Dr. Khan, Dr. Moin Khan. He's a professor in sports surgery who actually exercising in Maqdes University in Canada. He completed his medical and residency training as well as master's degree in health science and research methodology. So, you know, this guy is very smart in publishing papers and also criticizing papers and also working as a shoulder surgeon. So his interest is mainly shoulder surgery and elbow surgery, and his specific interest is in instability surgery. So he's giving us a very nice talk about shoulder instability and subacute injuries in the shoulder. So welcome to Dr. Khan.
Thank you very much, Ali. It's my pleasure to speak to you all today on recurrent anterior shoulder instability with subcritical glenoid bone loss. We'll talk about treatment options and evidence. We'll also do a little bit of an overview of anterior shoulder instability, and then I'll end up the talk with a little bit of some technical tips for a remplissage procedure, things that I've found useful. These are my disclosures, none of them are relevant to this talk. So why is this important? Well, the shoulder is the most commonly dislocated joint in the body. And in the United States, there are over 70,000 shoulder dislocations that occur annually, primarily affecting young male patients. And anterior dislocations are the most common form of instability, and recurrence rates are high. Subsequent instability overall is estimated to be about 14%. And with improved recognition of bony defects and their contributions to recurrent instability, this really has led to an improvement in our treatment algorithms. So sometimes things are pretty clear. The image on the left, I think in North America at least, most surgeons would perform some sort of a Bankart repair. The image on the right, with more than 25 to 30% glenoid bone loss, most individuals are looking at some sort of bony augmentation procedure, whether it is a ladder J, distal tibia allograft, iliac crest bone graft, but some sort of bony augmentation is required. Sometimes though, things are not as clear, and I'm going to illustrate that with a case. This is a 26-year-old gentleman who had initial dislocation 1 year ago in a fight. Subsequently, he's had 5 dislocations, 4 in the last 2 months, and they are otherwise healthy. And if you look at the imaging, they have 11% glenoid bone loss and an on-track Hill-Sachs lesion. So depending on who you'd ask, some people would recommend performing a bony augmentation or a ladder J procedure, and some surgeons would recommend a soft tissue repair. And so we're going to really look at the evidence surrounding this. Now, when talking about shoulder instability, one of the most important papers to come out is some work done by Dr. Boileau, the Instability Severity Index Score. And I think the importance of this really highlights risk factors that when we are seeing these patients in clinic, we need to recognize certain things that put a patient at increased risk of recurrent instability. And the 5 or 6 things that were identified in this paper were age, younger being worse, competitive sports, shoulder hyperlaxity, and glenoid or humeral bone loss. And really, you just need a glenoid lesion and a humeral lesion in a patient that is under 20, and you're already looking at a 70% risk of recurrent instability. So very important when you're seeing these patients in clinic to recognize these important risk factors. Now, when talking about identifying bony defects, there are many different ways to do that. There are specific radiographic views. You can estimate bony defect based on MRI, but really I think in 2020, the standard of care is a 3D CT scan, which will provide you with the most reliable imaging modality to evaluate bone loss. Now, when looking at 3D CT scan, this is a great paper done by one of my colleagues, Tim LaRue out of Toronto and the Rush group. There are advantages and disadvantages of different methods of measuring glenoid bone loss based on CT scan. And in general, these methods can be broken down into two main areas: diameter-based methods and surface area-based methods. And just being able to recognize that the pros and cons of this, I think, are important when measuring glenoid bone loss. The advantage of the diameter-based method is it is easy to use. In clinic, it does not require any specific software. The disadvantage is it may overestimate slightly the degree of glenoid bone loss. Surface area methods may be more accurate, but you require specific software to use them. So just as an overview, the diameter-based method is quite straightforward. A circle is drawn over the glenoid on face view. The diameter is assessed, and then the degree of glenoid bone loss can be easily measured. Whereas the surface area method, this is uploaded into some software, and then the specific area of the defect is calculated. Now, traditionally, there have been cutoffs of what is considered to be critical glenoid bone loss, and depending on what you read, 20 to 25% is widely recognized that this is considered to be critical and requires some sort of glenoid bone grafting. But I think now we realize that it's not just the presence or even the size of a bony lesion, but it is also the location of the lesion as well. And initial work with the engaging and non-engaging Hill-Sachs lesion was important, and really went a step further now with our understanding of on-track and off-track lesions. And I think it's very important for anyone managing shoulder instability to have a very good understanding of this track concept. That was done by Giacomo, Itoy, and Burkhardt. And we'll go over that here. So as a review, the glenoid track is the area of the humerus that articulates with the glenoid as the shoulder is going through a particular range of motion. And Hill-Sachs lesions that are larger and more medialized are more likely to engage off the anterior aspect of the glenoid than those that are smaller or more lateralized. And the method to calculate the if a lesion is on or off track is very straightforward. You start off by measuring the diameter of the glenoid from your best fit circle. You determine the width of the glenoid, and then you multiply that by 0.83. Then you subtract from that the amount of glenoid bone loss, and that gives you your glenoid track. Then you look at the humerus and you calculate the width of what's called the Hill-Sachs interval. So from the infraspinatus attachment to the most medial aspect of the Hill-Sachs lesion. If the Hill-Sachs interval is larger than the glenoid track, then the lesion is off track or engaging, and that is more likely to cause problems. So why is this important? Well, this is some great work done by Dr. Tokish, in which he evaluated patients that had on and off track lesions. In patients that had an on track lesion treated with a Bankart repair, only 8% of them went on to have subsequent instability. Whereas those that had off-track lesions, 75% of those patients went on to fail. So critically important to recognize whether a lesion is on or off track. And I think an area now that we are increasingly realizing and looking at is the area of what is considered critical bone loss. And traditional cutoffs of 20 to 25% may actually be overestimations, particularly in contact athletes or in military populations. This is another great paper by Dr. Tokish, in which he looked at 72 active military patients undergoing anterior instability surgery at a single military institution. And they looked at failure as both recurrent dislocations, and they also looked at WOSI scores, or functional outcome scores, postoperatively. And they divided patients into various quartiles or groups based on the percentage of glenoid bone loss. And what did they find? They found that patients that had bone loss more than 13.5% actually had an unacceptable outcome. So instead of that 20 to 25% threshold that is commonly discussed, you know, maybe we are definitely overestimating that, that glenoid bone loss. So I think it's important to recognize that patients present not just with glenoid lesions, they present with bipolar bone loss. So glenoid and humeral bone loss, where individual defects are subcritical in size and conventional glenoid-based treatment algorithms do not always apply. Probably the biggest takeaway from this talk, I think, is if you can recognize that subcritical bone loss is common, it's underestimated and unrecognized often. And an example of this is some work done by Dr. Walsh, a radiographic study looking at 160 patients with recurrent instability. 73% of those patients had Hill-Sachs lesions, and 78% actually had a Bankart or a bony Bankart lesion. What about CT scan? And this really highlights the importance of CT analysis in these patients. First-time dislocators, out of 218 shoulders that were scanned, 41% had some degree of glenoid bone loss, and in recurrent instability, 86% actually had some degree of bone loss. So what are our treatment options in 2020? I think when you're dealing with this subcritical bone loss patient, the majority of surgeons are doing one of two procedures, either a Bankart repair, increasingly adding a remplissage, or a ladder J procedure. And we'll talk about some of the evidence and the biomechanical basis of these procedures. If you're looking at practice across the globe, there is no consensus as to what is the optimal treatment. And that's really highlighted, I think, by the case I presented. This is some work done by Joshua Dines out of New York, where he surveyed American shoulder and elbow surgeons and presented two scenarios. A 20-year-old college soccer player with minimal glenoid bone loss, so less than 10%, or a 20-year-old college football player, so a contact athlete, also with less than 10% bone loss. And looking at respondents, 80% of respondents said in the non-contact athlete they would do a Bankart repair, and 56%, almost 60%, said they would do a Bankart repair in the football, a linebacker. So no consensus or no overall agreement with what is the standard of care there. What about in Europe? This is a survey of German orthopedic surgeons. They presented a scenario with recurrent dislocation with less than 25% of glenoid bone loss. 76% of participants said they would perform an arthroscopic Bankart repair, and 11% said they would perform some other procedure, whether ladder J or something else. So both of these procedures have their biomechanical basis. And this is a nice paper performed by Dr. Athwal out of London, Ontario, demonstrating the biomechanical aspects of the Hill-Sachs, of the remplissage procedure. And the way the procedure works is it converts an intra-articular defect into an extra-articular defect by tenodecing the infraspinatus into the defect, rendering it extra-articular and non-engaging. And they did a biomechanical study of a cadaver study with two types of Hill-Sachs defects, a 15% Hill-Sachs defect and a 30% Hill-Sachs defect, and they tenodeced the infraspinatus into the defect, and they found that the addition of the remplissage procedure significantly improved stability of the shoulder, particularly in the larger defect, although it did decrease some shoulder range of motion. What about the ladder J procedure? How does this work? This is a cadaveric study of 8 fresh frozen shoulders. They had translational force of 50 newtons applied to the humerus, and they looked at various positions with the capsule intact after the creation of a Bankart lesion, after the creation of a large glenoid defect, and then they performed the ladder J procedure, and they then subsequently sectioned the subscap, the conjoint tendon, and the CA ligament capsular repair to determine the individual contributions from all of these procedures. And they found that the translational force of the shoulder significantly decreased after a Bankart lesion or a glenoid defect, which obviously makes sense. The shoulder is more unstable, and it was reduced to near normal levels after the ladder J procedure was performed. And there were significant contributions from the sling effect of the subscapularis and the conjoint tendon, and some contribution as well from the suturing of the capsular flap. This is a little bit more work done by, again, Dr. Athwal and Dr. Ryan Deegan out of London, Ontario. where they found that both procedures, either the remplissage procedure or the lateral J, are effective in reducing dislocations in a 25% Hill-Sachs defect model. So when you're looking at these two procedures, both of these procedures actually have their advocates. And this is a nice systematic review comparing a lateral J versus Bankart repair in all comers. And they looked at 8 studies, and they found that the lateral J procedure is a viable and maybe superior alternative to the Bankart repair. And now you have to remember, these are all small retrospective studies, so low-level evidence. And the question is then, okay, if the lateral J procedure may be more effective than the Bankart repair, what about the addition of a remplissage procedure? Does that add more stability in clinical studies in comparison to a Bankart procedure alone? And this is a nice study coming out of Rush University. Again, small retrospective studies included in it, favoring remplissage versus Bankart in terms of improving stability. So obviously, it makes sense. Adding the remplissage procedure does improve shoulder stability over a isolated Bankart repair. This is a paper that's not yet out, but has been presented by Peter McDonald out of Manitoba in Canada. A randomized control trial, so high quality evidence, looking at patients who had either a Bankart repair or a Bankart repair plus a remplissage procedure. And they found that in those patients, particularly at higher risk of redislocation, again, this level 1 study demonstrated a statistically significant decreased risk when the remplissage procedure was added. Now, what about complications? You know, some people say that, or many people are concerned of the complication rate with either or particularly with the lateral J procedure. This is a systematic review looking at risks or complications after the lateral J procedure, and they found up to a 30% reported complication rate with the lateral J. Now, it's important to again recognize that these are all small, often non-comparative studies, and comparative studies show that the complication rate is significantly lower, and we'll touch on that slightly later. What about the learning curve of the lateral J procedure? It is a technically challenging procedure. This is some work that we've published that showed that you need at least 20 or so procedures before you are technically proficient with this and your risk of complications decreases. So let's move on now to looking at some comparative studies, looking at the lateral J procedure and the remplissage with Bankart in subcritical bone loss. So really focusing now on the population of interest. This is a nice paper that had 40 or so patients in each group. This is again a retrospective cohort study. They had similar baseline characteristics in each group. And they found that actually there's no significant difference between a Bankart with remplissage versus a lateral J in terms of functional outcomes or recurrent instability. Here's another great paper, again done by Dr. Arciero. Almost 190 patients, or 90 or so in each group. Again, subcritical bone loss, similar size glenoid and Hill-Sachs lesions. And again, what did they find? No statistically significant difference between these two groups, those that had a remplissage procedure and those that had a lateral J procedure. But the complication rate was significantly higher in the lateral J procedure, 12% versus 1% in the remplissage. This is a third paper, again, about 30 or so, 35 patients in each group, randomized to Bankart with remplissage versus lateral J. Again, no significant differences in outcomes. If you look at all of the comparative studies, this is some work that we've done. I think some of the take-home points that you can glean from the low quality evidence is that recurrence rates are higher with Bankart remplissage versus lateral J, particularly when looking at glenoid bone loss more than 10 to 15%. And complication rates may be higher with the lateral J procedure than those with the remplissage. Now, the important thing to recognize when looking at the literature is there is no comparative randomized control trial that has been completed yet evaluating soft tissue repair, Bankart with remplissage, in comparison to bony procedures, such as the lateral J, in this scenario of subcritical glenoid bone loss. So when you're making your decisions for your patients, if you're making decisions based on cohort studies or case control studies, really you're doing a disservice, or we are doing a disservice to our patients, because we are not applying the highest level of evidence available. So really, if we have randomized control trials, it is much more useful when we are making treatment decisions. So this is actually a trial that we are leading out of McMaster University, and this is an international study looking at instability in subcritical glenoid bone loss, comparing the remplissage procedure with the Bankart repair versus the lateral J procedure. So stay tuned for those results when they eventually come out, and we can definitively answer this question. Now, just to end off the talk, I'm just going to briefly go over some surgical tips that I find useful when performing a remplissage procedure. I utilize four portals: anterior portal, high interval portal, posterior lateral portal, and my posterior viewing portal. And you start off with your routine diagnostic arthroscopy, and then I like to establish my anterior and high interval portal. And so the high interval portal just comes above your above the biceps tendon, just anterior to your supraspinatus. And then I like to transfer the arthroscope into that portal, and that gives me really this on-face view of the glenoid. So when performing the Bankart repair, you can instrument through the anterior portal and really have a great view while performing that. Also, from this high interval portal, you're able to look at the Hill-Sachs lesion and bring your anchors through the posterior portal, and that results in a more favorable trajectory for the anchors in comparison to a posterior lateral portal. I then redirect the sutures from those anchors through the posterior lateral portal to allow for a more favorable trajectory through the tendon. I think some important points when performing this procedure really is to place your remplissage anchors initially before you perform your Bankart repair, and then perform the Bankart repair and then tighten your remplissage suture anchors at the end. If you do the Bankart and then you're placing your remplissage anchors, you may disrupt your Bankart repair. And if you tighten your remplissage anchors before your Bankart repair, then the shoulder does close down quite a bit and makes it difficult. And the picture on the right here, you can see the infraspinatus is now tenodeced into that defect. So just to end off, I think some take-home points from this talk. The first one is really recognize glenoid bone loss and bone loss in general, bipolar bone loss. So the 3D CT scan is your friend. It's important to understand the importance and the role of bipolar lesions and really have a good understanding of the track concept and apply it to your patient care. Subcritical bone loss, it is prevalent and underestimated. Available low quality evidence currently suggests that if you're looking at over 10 to 15%, recurrent instability may not be well managed with a soft tissue repair, and you may be looking at performing something more, and either adding a remplissage procedure or a lateral J procedure. And really, we need some high quality research to definitively answer the question of the best treatment option in subcritical bone loss. Thank you very much for your time.
Thank you very much, Dr. Khan, for this very conclusive talk. Moin, I really thank you for joining us and giving us and sharing on your knowledge.
My pleasure. Thank you very much for inviting me.